Well, thank you for sticking around for our symposium today. I hope you enjoyed the first session. Screening is very important and it keeps changing. Not too many things change, but that's really important to keep on track with this and know what's the latest on this. New technology is making screenings more efficient and more effective, hopefully. The next session, this session, is quite interesting, I find. The first part, I'll be speaking about the effect of COVID on cancer care. The effects of COVID on cancer care have been dramatic, and it's a big subject. I'll try to cover it within less than half an hour. But we also have Dr. Chris Kearney, who is in charge of MedStar Palliative Care Network. Dr. Kearney is an outstanding speaker on the subject of palliative care, and I thought this would be an interesting presentation for you to attend. And Dr. Mohab Tash will close the session with a presentation on monoclonal gammopathy. It's not a very popular subject, but a lot of doctors have requested information about this subject. So this meets the needs for our community. And remember, if you complete the survey, you'll get your 2.75 hours of credit for your CME. I will dig into my presentation, and the title is The Impact of COVID-19 on Cancer Care. In this session, I will try to discuss the impact of the pandemic on cancer care, focusing on delays of treatment. I will introduce alternative treatment strategies and options, and I'll try to create a framework for understanding the prioritization of care. And I'll have a small introduction on telehealth. This is exciting. I think telehealth is going to be very important in the future of medical practice. I have no relevant disclosures on this subject. The CDC has highlighted the delays in cancer care. This is not only the CDC, actually, the National Health Service in the UK, and reports from all over the world indicating delays in cancer treatment, which could be costly for patients and could increase mortality and costly for society, obviously. The CDC reported that 4 in 10 US adults avoid medical care because of concern about the COVID-19 epidemic. Unfortunately, people with disabilities and people with 2 or more underlying conditions are the ones that are affected the most, and these are the ones that cannot afford to delay care. So the CDC goes ahead and encourages people to go back to treatment. If you're sick, seek treatment. And I'll go into some details about that. And they throw a dig for telehealth, saying this may help deal with this issue. I wanted to show that this is a universal experience. Dr. Papowski from University of Illinois surveyed 609 breast cancer survivors, and she reported almost the same numbers as the CDC. 44% reported delays in all aspects of care, diagnosis, surgery, radiation, chemotherapy, and so on. That's a big number, and what's as disturbing is that younger responders reported higher incidence of delays, which is also quite concerning. In our environment, you know, our breast center here at MedStar Good Samaritan Hospital covers both this hospital and the MedStar Uni Memorial Hospital community. We actually are now covering a little bit of the Harbor Hospital as well. We've seen the volume reductions in screenings, surgeries, medical and radiation oncology visits. Actually, in the beginning, we have a complete shutdown of all screening activity, cancellation of elective surgical procedures. And it took a long time to start recovering. We started opening up a little bit and slowly and carefully in July, August, and now we're up to about 80% of our baseline volumes. We're seeing delays in the diagnosis that were rarely seen before. We used to see them, but very rarely. Our network, MedStar Health Cancer Network, have had 2 groups actually looking and meeting and creating solutions to deal with these issues. We have the MedStar-wide group, and we have our MedStar North group dealing with the issues of mitigating the effects of the epidemic. These were led by Dr. Arifai from Georgetown and Dr. Abul Afia here in Baltimore. An example of patient delays is this 61-year-old lady who I saw last week, and I did a biopsy last week. This is a large fungating tumor that's been growing since March, but she was afraid to come to seek help. And I did the biopsy in the office showing a ER/PR negative disease, HER2 positive disease. The ultrasound on the right side, they couldn't capture the whole tumor with the ultrasound, but shows how vascular the tumor is. These tumors are pretty aggressive. These patients respond extremely well to preoperative chemotherapy. The standard protocol for them noted below may achieve 50% complete pathologic response, especially in the ER/PR negative HER2 positive disease. And that's why these patients have to come and have to be treated. Otherwise, we see this type of problems. How do we measure, how do we balance whether the danger from COVID is higher or the danger of the cancer? For example, if you have a low-grade prostate cancer, it probably could wait a significant period of time before being treated. So it'll be wise for patients to wait. There, the balance is for delaying the cancer treatment. An interesting tool I ran into was developed by University of Michigan. This is the link for it if you're interested to check it and use it. The link allows you, it's free online, and you could estimate what's the risk of COVID versus the risk of delay of treatment. And this way, people could make informed decisions. I have to warn you that the risks of COVID might vary with time and location. So I wouldn't count on that 100%, but it's additional information that one could use to calculate the balance of risk that we're talking about. We have also received a lot of guidance on how to deal with this epidemic. I'm listing here only a small number of societies, and they really have been very progressive and moving forward with this. We have the American College of Surgeons have had good leadership role. ASCO, the American Society of Clinical Oncology, the Society of Surgical Oncology, the American Society of Breast Surgeons, European Society of Medical Oncology, and U.S. Colorectal Cancer Alliance. Many of them have worked together to give us guidance on how to deal with different cancer sites. I can't cover all these cancer sites, but I'll give you a taste going through breast cancer. For breast cancer, the guidance is largely agreed upon by the American College of Surgeons, the ASBS, and SSO. For example, they say these patients should not delay treatment. These are patients who have completed preoperative chemotherapy for triple negative or HER2 positive disease. These are patients like the patients I showed you who received the chemotherapy now. The tumor is suppressed and they're ready for surgery. These patients should be operated in a reasonable period of time. Similarly, patients who progress on preoperative chemotherapy, we don't see that very often, but if a patient is getting the chemotherapy and the tumor is not shrinking, these are patients who should be expedited. Inflammatory breast cancer is another situation where we move on with surgery after completing preoperative chemotherapy. And these are the type of things, the guidance that really helps us make decisions. There are, however, a lot of patients who can be delayed. For example, patients who have DCIS and are ER/PR positive. DCIS may take years to turn into a cancer, maybe at most months. These patients could be treated with hormonal therapy and treatment could be delayed, as well as patients, especially with small ER/PR positive HER2 negative disease. These patients almost always respond or stabilize on hormonal therapy, and there's probably no loss of survivor if you just give them a few months of hormonal therapy before the surgery. Other things that should be delayed are atypical or high-risk lesions where the chances of malignancy is small, and these could be small tumors anyway, or reconstructions, prophylactic surgery, and other benign disease. So I'm going to give you examples of where does this work. This is another patient I saw last week. This is a 53-year-old who felt a mass in her breast about a year ago. She thought it's a bruise because she felt it when she hit against a wall or something, which is often what happens. Patients think it's a bruise, but that's when they notice the mass. She had ignored this tumor till January, February, and she thought it'll go away. It did not, so she decided to seek care, but then the epidemic care, and she did not show up till October. A needle biopsy of that showed a nasty tumor, an aggressive tumor. These are triple negative cancers who do not respond to, that don't respond to hormonal therapy. They respond only to chemotherapy, and they need surgery, and she needs radiation. You could see the tumor on the left side, and you could see how it occupies much of the breast on her mammogram. So that patient, if she came in February, she probably would be treated. If she came in March, you start thinking, well, we need to treat her. If she came in the height of the epidemic in New York City or Brooklyn or something, then it'd be a different ball game. So this is, the American College of Surgeons came up with this classification of the phases of the pandemic to help people make these decisions. So they have the acute phases. They've put them into three phases: phase 1, 2, and 3. Phase 1 is the beginning of the epidemic, when resources are still available, and when you would treat patients at that phase, because you're predicting that things are going to go bad, but that might take weeks for that. So we kind of take care of these patients right on the spot. Phase 2, the resources are becoming tight, and you only treat patients who will be harmed if they wait more than 3 weeks. Phase 3 is in the height of the epidemic, where you only deal with emergencies. So this is the kind of logic you need to use. Then you get into the phases of recovery, which we went through at our organization in opening up resources, whether it's diagnostic, screening, and operating room resources. These are examples of patients that we treated during the epidemic. The first patient on the left side is an ER-positive tumor. As you can see, if you look at the screen, this is less than a centimeter in size. There's no reason to operate on that patient in April or May. This patient received hormonal therapy for 4 months, and recently we did a lumpectomy with sentinel lymph node biopsy and intraoperative radiation therapy for this patient, and she did well. This is the logic that we need to use. One thing, I'm going to throw a dig for intraoperative radiation therapy. We've done a large number of patients with excellent results, and for this patient will avoid 20 or 30 visits to the radiation center and the hospital. It's not applicable for everybody, but this is a good patient for that. The patient on the right is a patient with a small DCIS. She's 59 years old. Her tumor is ER/PR positive. Again, hormonal therapy for a few months, then surgery. Colorectal malignancy is another place where tough decisions have to be made. So if you have nearly obstructing colorectal cancers, these patients have to be treated. Might not be that they have to be treated within the next week, but they can't wait a month or 2 months. They come back to the emergency room obstructed with high mortality. That's not good. There are patients who are constantly bleeding, requiring transfusion, patients who are symptomatic, rectal cancers where neoadjuvant chemoradiation did not do well, they didn't respond well to that. Patients where there's a concern about the local perforation where you'll end up with an emergency operation, not good. So the Alliance for Colorectal Surgery have recommended that these patients be expedited However, patients with malignant polyps or prophylactic indications for surgery or large benign appearing asymptomatic polyps and so on, these could wait. For lung cancer, which is another common cancer we treat, there's an international consensus group that provided guidance. I don't know much about lung cancer, so I'm not going to delve into the details of that. So at the end of the day, therefore, what one has to do is really balance the risks and benefits, and to the best of their judgment and guidance from organization and through a multidisciplinary discussion, which is what we do for all our cancer patients, and make the right decisions for the patients and for the staff. You don't expose your staff and the operating room staff and anesthesia and the hospital staff to patients if it can wait till the epidemic is subsided. This brings us to the role of telehealth in all of this. Telehealth has been very helpful for many of us. I thought this is interesting. You can't list your iPhone as your primary care physician. Introducing telehealth here. What's key about the role of telemedicine in our practice is picking the right patient with the right use case with the right diagnosis. You can't do a gynecologic exam through telehealth. You can't operate on patients through telehealth, but you can check on their compliance with their medications. You could check on if their incisions post-operatively. So you have to be selective where you use telemedicine and telehealth. What's another key factor, once you determine which patients are appropriate for a telehealth visit, you have to prepare for the visits. To prepare for the visits, the provider has to review the record. They have to know what they're talking about, the same way we review a record before we walk into a patient's room. You define what information should be collected before you encounter the patients, such as their chief complaint, past history, social history, allergies, medications. This is often done by our help in the office, whether it's medical assistants or otherwise. Collecting that information and us being aware of it before we see the patient makes the encounter much more useful. And then you get ready for the visit. There are some etiquettes for virtual visits, obviously. You have to dress appropriately. You can't be unprofessional. You have to be on time. The patients, from my experience, when you tell them you're going to call them or you're going to invite them, they're ready, they're waiting, and they get anxious if you keep them waiting. If there are other people with you, introduce them. I tend to use a chaperone in most cases. I think that's important, especially people could be talking about private things or maybe showing you an incision in private areas and so on. I think it's important to have a chaperone, if at all possible. You need a quiet location, appropriate background, and make sure your technology works before you invite them, so internet connections. And you have speak up, no mumbling, and you mute your microphone if you're talking to the staff next door, if there's a little noise outside. Some physical exam findings could be obviously ascertained by telehealth, obviously, so you can ask the patients where the pain, to touch parts of their abdomen, especially in low-risk situations. And another aspect of telehealth, it could be a good team effort, like a multidisciplinary, or other trainees, physicians, residents, nurses could be on the meetings. Zoom meetings allow you that. I think that's an additional advantage to the face-to-face encounter. At the end of the day, when you finish your encounter with the patient, it's important to plan and wrap it up. You have to reach a conclusion with instructions to the patients. Review the recommendations clearly with the patients, recap suspected diagnosis, outline a treatment plan, send handouts, delegate next steps to somebody. Teresa will schedule you for a mammogram. Deborah will call you in 2 weeks to check on you, so on, so that there's a closure to that encounter. There are many telehealth options. And when surveyed, physicians felt that the most important thing about telehealth is the ease of use by patients. That's the biggest barrier. So whoever designs and uses a telehealth platform, make sure it's easy for the patients. That the next thing that's important for them is the reliability. Then it's ease of use by provider. That only ranked at 30%, because I guess you count on the providers being able to do this. And only 19% really cared about the security as much as organizations do. These are virtual visit platforms that are available. Some of them you pay for them. Some of them I think are almost free. But this just, I'm putting this so that you know that there are options for providers to look at. The thing that brought telehealth into the picture is changes in the law. Medicare allows, Medicare will pay for these telehealth visits for also all kinds of providers, including physicians, nurse practitioners, PAs, clinical psychologists, licensed clinical social workers, and so on. So that brought telehealth alive for everybody. The other things that made telehealth easier to adopt is some relaxation of the HIPAA rules. The government said we're not going to enforce HIPAA rules during the pandemic, which really helped people use some of the FaceTime and other non-secure modalities. Also waiving federal licensing regulations. This enabled physicians to treat patients in different states for via telehealth, and also payment parity, which is really important. Finally, I'm not going to delve into this too much, but we have 3 types of telehealth visits. The telehealth visit, which is audio and video. Then there's the telephone visit, which is also paid for, which is audio only. And the e-visit, which is online messaging, but these have to be initiated by the patient. The impact of telehealth on the way we deliver care has been dramatic. The green is face-to-face encounters. Throughout the world, the face-to-face encounters became the minority of encounters during the pandemic, except in China. So that's interesting, and I don't know where it's going to settle down eventually. Having said all this about telehealth and its safety and efficiency, don't forget that face-to-face encounters with mitigation could be very safe. This is an interesting study from Massachusetts. 4 Harvard hospitals, 3,000 deliveries, out of which 111 patients tested positive when they went into labor. That's about 3.7% of that cohort. They matched each one of these patients with 5 controls, and then from the electronic medical record calculated how many in-person encounters that each group has. The number of in-person encounters was 3.1 encounters for the positive patients and 3.3 for the patients who tested negative. This just suggests that there might not be a huge danger from face-to-face or in-person encounters. Does not answer the question, but challenges the concept that's dangerous to have in-person encounters. Another thing that really highlights the importance of telehealth in the future is what the Cleveland Clinic Foundation calls side effects of the in-person visits. Lost wages, death from accidents, paying for gas, tolls, child care, so on and so forth. So I think a lot of people are going to find telehealth convenient in the future, and I think it's going to stick around. The key is answering the questions: who are the best patients that you can apply telehealth to? So I'll finish here and conclude that delays of cancer screening and treatment are dangerous and costly. Prioritizing diagnostic and treatment intervention is based on a balance of cancer risk versus COVID-19 risk, and we have increasing number of tools to help us with that. Systems devised to manage different epidemic phases are important so that we know what to do at different phases, because it's a fluid situation. Mitigation of risk, very important. Masks, hygiene, distancing, we should apply these in a very disciplined way. And a systematic approach to telehealth implementation is key to its success. And I think telehealth is here to stay and would likely improve care and reduce cost if properly implemented. Thank you for listening, and happy to entertain any questions.